gentlemen, and thank you for allowing us to come to St One this afternoon to talk to you about our proposals about how we would like to think about delivering health and care on the island differently going forward. The model that we're about to show you is a model that has been co-created by clinicians from across the island, clinicians in our GPs, pharmacists, dentists, doctors who work within our hospital, and people who work within our voluntary sector. The format of this afternoon is we're going to do the presentation, and then at the end there'll be an opportunity for you to ask questions. We're conscious that some people don't feel comfortable standing up and asking questions, so there's an address for you to be able to send your feedback to afterwards if that's easier for you. We are filming today, but we're just filming for our own purposes, and we won't be filming any of the questions. So, I'll just ask the team to introduce themselves. I'm Karen Landon, I'm Director General for Health and Community Services.
I'm Stephen Bull, Head of Change for Health and Community Services. I'm Rob Sainsbury, I'm the Group Managing Director for Health and Community Services.
Hello, I'm Rose Naylor and I'm Jersey's Chief Nurse.
Good afternoon, my name is Patrick Armstrong and I'm the Interim Medical Director.
So I'm going to ask Patrick to start.
Indeed, thank you very much for coming out this afternoon and listening to our presentation. As I say, I'm the Interim Medical Director, but by trade as such, I'm an orthopaedic surgeon with an interest in upper limb conditions. And I came to Jersey 3 years ago. I'm delighted to say that I live in this parish, just down towards the 5 Mile Road. And I think when you come to Jersey, you very quickly realise that it's different. And many of those differences are absolutely wonderful. The sense of community, the parish system, and for me as a health professional, that connectivity I have living and working amongst the people that I serve. But I'm not sure in terms of delivering healthcare, that connectivity that you see within the community transports itself into how we interact between services. So for me, sitting in secondary care, do I communicate well enough and have enough contact with my primary care colleagues, with social care? And sometimes it just feels a little bit disjointed. And I think what we're saying here is, can we do it better? Is there a better way of doing it? And what I've seen through my career, I've worked in the north of England as a consultant in Guernsey, often the way healthcare develops and evolves over time is it's related to the building that you work in, the teams that already exist, the skill set that people have at a particular moment in time. And the question is, are those the right drivers for change? The reason I completely support this model, and we'll see this in a bit, it puts patients at the centre. What is it that the patients need? And I think possibly we may have got a little bit away from it. My job really is to describe services as they are now. And bearing in mind what I've just said, in terms of secondary care, it's largely centred around these three institutions: a mental health facility, our rehabilitation facility, and of course the general hospital in Gloucester Street. I like facts and figures. Here's just a few that have really made us think about, is the way that we're delivering healthcare at the moment the right way or not? Not going to go through all of them, but just a few highlights. This one at the top. Just under 40,000 people attend our emergency department every year. We think 75% of those, nearly 30,000 of those people, could be more appropriately cared for in a different way. About 10,000 of those people really need to be seen in the emergency department. Our conversion rate, that's the number of people who attend the emergency department who end up being admitted to hospital, is at about 14%, and that's one of the lowest, if not the lowest, in the UK. And that may sound as though that's brilliant, we're sorting everyone out, we're treating them well, but in fact it probably means a lot of those people shouldn't be there. The emergency department's set up to treat people who are really seriously and acutely ill, who may need resuscitated, who may have serious injuries, and that's what they're good at. And if there's an awful lot of other people with other conditions, maybe that's a distraction, and maybe those people aren't getting the service that they need. I'm going 189,000 appointments in outpatients. I feel that, I sit in clinics. And in fact, this year it's going to be nearer 200,000. That's not sustainable. That is massive, and if you look at any other health economy, we are a bit of an outlier. There's far more people attending our outpatient department than you would expect. The new to follow-up ratio probably explains that. That's for every new patient that we see, we'll see that person on average almost 3.5 times again. There are reasons for that. I sit in my clinic and it's good to see people after surgery, after I've operated on them, but I'll be doing things like signing sick certificates, prescribing them analgesics, checking their wounds. That's fine, I enjoy doing that. I enjoy meeting patients after surgery, but when I've got a 3 to 6 month waiting list to see new patients, is that really a good use of my time? Could other people not do those sorts of things for us? Our rehab day, average length of stay, so when people leave the hospital for rehabilitation, so they often do in orthopaedics, they say on average about 5 weeks in that facility. That's a very long time. And the reason is, when they want to move from that facility into the community, those services, well, they are there and they're brilliant, there's just not enough of them. Our day surgery rate, 65%. That's about what my day surgery rate is at the moment. It's always been about 85%. People are coming in, staying in hospital overnight when they really don't need to. And if we could do things in a different way, then we could get more people home the day of surgery, which for most people, that's what they tell me that they want. I think this graph is really important. What it's showing is, or what it's really a reflection of, is the number of people staying in either an acute hospital or a rehab facility for more than 7 days. And as I expect, going through the age, a bit of a peak for younger people, but as you get older, you spend more time in hospital. But again, that's far more than you would see in other jurisdictions and other health economies. The reason that is important is this graph, and I see this on a day-to-day basis. So what it's saying is if you're 80 and you spend a week in hospital, you may lose 1.5 kilos of muscle. You may lose 20% of the strength in your quadriceps muscles. And for me, if that happened to me, yes, it wouldn't feel great. I would feel a bit weak, but it wouldn't have that much impact. If you're 80, that may be the difference between you being able to walk or not, being able to get out of a seat unaided or not, the difference between independent living or institutionalised care. And it's not something that you can correct quickly. If you lose that amount of strength, it can take 3 to 5 years for you to regain that strength if you're in that age group. Just getting back to how our services are set up at the moment, in addition to the hospitals, the GP practices are largely centred around St Helier and St Relad. About just over 80% of GP appointments are either in St Helier and St Saviour, and we just wonder whether that could be spread out across the island, be more accessible to more people. If we then look at our optometrists, if we look at where our dentists are, if we look at where the pharmacies are, and indeed where our care homes are, they're all clustered in small parts of the island, and there's large tranches of the island that just don't have any of those services. And while it's not a big island, we all know that getting around the island and transport links, that can be very challenging. This graph, again, I think is quite telling. What it's showing is the number of people who are either in residential care or nursing home care per 10,000 population. Jersey is on the right. There's a massive outlier. Far more people living on this island are spending longer times in residential care. And again, that may be correct, and for some people that is what they want. But surely we could look and see if there's some other way of keeping them at home and providing choice. It's just a reflection of the services at night. They are quite rightly centred around St Helier, the police, fire service, out of hours doctor service, because most people are in bed, they don't need that service. But there will be vulnerable groups groups out there who may not find it easy to access those services. And again, that's something that we think that we should look at. I'll hand over to Rob to perhaps expand on that.
Thank you, Patrick. And so I just want to talk through the connectivity of the system, really building on what Patrick has described to you. And you'll see from the information that we present around the care model that buildings are really the focus of care within Jersey. And we are starting to see a big connectivity between the hospital and the wider care system. So for our hospital, we are just starting to experience significant pressure in discharging our patients back to their usual place of residence, back to their home, particularly if you're frail or vulnerable or you have chronic conditions that mean you need a lot of support. And the reason we're struggling with that is because the home care market within Jersey is really becoming very fragile. It's quite difficult to get carers, it's quite difficult to provide the number of hours needed to support people in their own homes. So this summer, and all year really, we've seen a growing trend of more and more patients being discharged directly from the hospital into residential or nursing home settings. And often, that is not what the patient wants to do. They don't want to go there, they want to go home, but we simply cannot get the care and the support needed to help them with that wish. One of our most ambitious providers in the island, Jersey Hospice, provide inpatient services in the hospice, and they also provide community services. And the majority of people they support will say that for their end-of-life care, they also want to be at home, and they want to be around their family. They want to be in a familiar environment rather than the physical building. But they're struggling to be able to accommodate that because they're not supported by robust community services that operate 24/7, 7 days a week, with proper medical cover and wider multi-professional support. So a big part of their activity also happens within the building rather than at people's homes. As Patrick mentioned, for rehabilitation services, most of our activity goes to our ward in Overdale called Samaray. And when you get there, you stay there for about a month. But sadly, a very high proportion of those patients, rather than again going home, they are going into what we would call institutional care, residential nursing home care. And the big drawback for that is because when you've had a short period of rehabilitation, all the evidence tells you is that you really need to continue that rehabilitation for much longer than the inpatient episode, and you need to provide a service that's often called reablement. It's physiotherapy inspired, where you have support from workers who come into your own home and they help you to get back on your feet, build confidence, work on exercises, and become more independent in the way you manage. And we just don't have that service at a very robust level in Jersey. We've got a very small team, but they're not able to provide that service to everybody. And we think that should be an offer everybody should have. For mental health, unfortunately for this area, nearly all of our investment at the moment is within the buildings. So Orchard House and Clinique Penel at the St Saviour site is really where all our staff, or most of our staff, and most of our funding is. So if you look at what we're doing within the government plan, for these services, you really want the community to be the area where you've invested. That is how you support mental health, because the building deals with the crisis point. So all of these functions, where nearly 80% of our workforce and our resources, they're all dealing with the point where somebody's got into trouble, they're not well, and they need what we call acute intervention. They're being crisis managed effectively. For GPs, I've been around to all the GP practices on the island, and we've actually got a good prevalence of GPs on the island. If you compare us to the UK, we do fairly well. We're seeing some pressure, some recruitment pressure, and we think we need to do something different to incentivise GPs to come here. But generally, it's a good service if you can afford to pay. But what we're clearly seeing is that the hospital particularly is retaining a huge amount of activity and attracting a lot of activity because the hospital is free at the point of access. GPs are paid for services. So a lot of our chronic disease management, our asthma, our diabetes, our respiratory conditions, general frailty, things that are actually family medicine that a GP is really, really good at, it's their bread and butter. They're not able always to carry out that care because the patients are being held onto and are also going to the hospital, and the front door of the hospital really demonstrates that. People are going to the A&E department rather than their GP because one is paid and one isn't paid. For community services, we've really got some fantastic services in Jersey. Some of our services to stop people becoming unwell, a service that we call Rapid Response is really, really good, but it is very, very small in terms of how the team is configured. And this was really the big part of our strategy that we had within health for many years. We called it P82, and it was all about getting care in the community. And we've not quite realised that vision in the way that we would have wanted to. For Jersey, looking at our demographic, one of the biggest areas of investment and workforce that you really need on an island like ours are things like district nurses. We really need community nursing out there within the parish-based system, but we have very few. We don't have the right number that will be recognised internationally for how many community-facing nurses you have. So we've got some real deficits. It doesn't operate 24/7. We don't have night sitting. We've got some issues in capacity within this area. In social care, as I mentioned, what we call our domiciliary care, so carers who come into your home, this area, the market is now starting to deteriorate quite rapidly. And with every week, the hospital is seeing more and more and more patients who we just can't discharge back into this service because the carers aren't there. It's a very low-paid industry to be working in. It's very transient. People are moving around and around and around, and it's becoming unsustainable. We're not able to deploy it with confidence to provide the services. And as I mentioned, community mental health is very mature on the island. We really need to build on that service. Probably the strength of the system that we've got now, and it was demonstrated in Patrick's slides really, are the services that provide direct access. So if people can afford them, there are an abundance of direct access service from dentists, pharmacists, optometrists, and I would say the GP to a degree as well, although there are differences across the patch. The voluntary sector is absolutely vibrant. There are over 450 charities, which is huge, very, very significant. And the parish-based system is something that most jurisdictions would really, really want and don't have. It provides a huge strength, the way that we can deliver services, but it's probably not utilised in the way that it really should be. And we've not done a great job in joining all of this up. Our computers don't talk to each other. Our staff sometimes don't talk to each other, and what patients are telling us is that they tell their story many times to many different professionals, and they go round and around and around, and we see them coming in and out of the hospital, back to the community, and we're seeing a real cyclical pattern, and we want to stop that happening. We want there to be better care and coordination. So that's how the model really is proposed to change. It starts becoming person-centred. All of the research, wherever you are in the world, is telling health and care that you have to get upstream in the way you deliver services. Prevention is absolutely key to delivering good health and care. If we can start to catch problems before people get into problems of crisis, we can get much, much better outcomes. We think education has a big role to play with that, and we need to do more to support people to take care of themselves and learn how to manage their own care and their chronic conditions particularly, and there's a lot of technology that can be used to support that. We want to connect physical and mental health because our patients don't often come with one or the other, they often come with both. Physical health problems often manifest themselves and lead to mental health problems as well, and we've got to start thinking about both of those areas. So well-being is incredibly important. But we also think, given the landscape here, it is quite complex for a small island, we've got to do better with coordination and communication for patients. We need our clients and our patients to understand who they call, who they speak to, who will do what for them when they have a problem. And we think we've got to align our services differently for more immediate communication with our patients. Where we would see the biggest change in the model of care we're proposing is within primary and community care services. So for community services, we would propose that we have a much bigger community service, particularly community nursing, district nursing, specialist nurses in the community, social workers, OTs, physios, and a much more robust home care market that we feel we would probably have to incentivise. We need to connect home care to our wider profession so that people going into that industry understand how they can have career aspiration, how they can develop, they can be the future doctors, nurses, physios of the future. At the moment, that's quite difficult for them. Primary care also has a really important role for us. In talking to our GPs, we're really confident that there is a lot of activity within the hospital that GPs can start to manage. Those 189,000 appointments that come into the hospital, a huge volume of those appointments can happen in people's GP practice. And we are confident that we can work differently with GPs to make sure that if people need to access those services with their GP, they don't have to pay for it. We will still fund those services. So if I've got asthma, and previously I would go into a respiratory clinic within the hospital for follow-up appointments, for checkups, in the future I would go to my GP to have that, unless I really, really needed to see a respiratory consultant. In going to the GP, I wouldn't pay for that service because previously it was free at the point of access for me in the hospital. So we would commission and contract with GPs to pay for that activity within the GP setting, closer to people's homes and with practitioners who are better at managing your total health need. We would also tie together the voluntary sector. So we want this area, which is fantastic, to be more collaborative in working together. There's a lot of competition here, there's a lot of overlap. We think that these services, paid services and to a degree volunteers, can really start to enhance the care that we give, and we want to bring them together as part of that community service offer. So we've been talking to all our providers about how we can start to make that journey and bolster the community services that we have. And then the hospital becomes really what the hospital is there for. If we can manage activity differently in the community, it frees up the hospital to deal with waiting times, to be able to get people in for their operations, to get their diagnostics in a quick fashion, and to have their treatments when they need it. At the moment, that is becoming difficult for us because we have a huge volume of activity that doesn't need to be there. And it makes it hard for us to then focus on the real stuff that we have to do because we're simply full. We're full of a lot of stuff that we shouldn't. So this has some big differences for the way we want to configure the way we deliver services in the future. And you won't be surprised to hear we've had to think about what does this mean for the future hospital, which we still need. At the moment, we have about 193 beds open in the general hospital. We can go higher, and we sometimes go lower than that. It's seasonal variation. Generally, we never go above 75% occupancy in the hospital. That's quite good. There aren't any UK hospitals that would be operating at that level. We think we need that. We're in Ireland, we don't have another hospital, we need to preserve that capacity. In the previous future hospital business case, there was a feeling that we probably need about 280 beds. The modelling we've done, and we need to do more modelling on this, is saying actually, if we really invested in community services, if we really made sure the hospital was working as efficient as it could, our modelling is saying you could actually have around 200 beds, you could actually go lower if we were the very best in class. But a conservative amount to keep our occupancy at the moment is saying around 200 beds, and you actually need more than 80 beds worth of activity in the community. That's underestimated, because the volume and the demographic will need much more than that capacity. We don't think that would be suffice, and we don't think the hospital would be the right area to focus that. We also need to look at the wider care setting, particularly community services and what we call intermediate care. So the services that stop people going into hospital and help people come out of hospital quicker are the services that would really build up on our community and impact on the number of beds that we need. The hospital would then focus on the specialist services that you really need in it. We are proposing that mental health is part of the future hospital proposal. We shouldn't have difference between physical and mental health, and our clinicians are saying they think there should be a co-located facility so you tie together those services and integrate them and get those professionals working together. For those of you who are familiar with the Westaway Court concept, that's what we called phase 1 of the previous future hospital plan. We wouldn't have that concept going forward. Our feeling is that was quite a big outpatient service. There was a lot of planned care activity that would be going into that facility. We're confident that a lot of that activity can be parish focused and particularly GP focused. We don't need a big building to bring everybody in for all of those activities. And at the front of the hospital, looking at our activity, as Patrick mentioned, we need an emergency department, a fully functioning A&E, which is there to manage those 10,000 people who absolutely have to have access to A&E. But for the 30,000, so the majority, we are proposing that we have an urgent treatment centre that is co-located. And that's because that centre can support minor illness, minor injury, and connect people back to their primary care and their community system of care. This is really important. Our clinicians, in the same way that we have to prioritise our operations, for patients coming into A&E, they have to prioritise the sickest patients. When your department is full, and you have a lot of patients in that department who don't need to be there, that presents a challenge for our A&E clinicians. And they're absolutely clear that we need to separate and prioritise the streams of activity so that really unwell people can have the attention that they need and you don't have that big volume pressure. For social care, we would incentivise the home care market, we would grow that, and we'd like to use the residential and nursing care sector differently. We'd like to use that in a more step-down way. We'd like to use it in a different kind of a model of care. We'd like to think about things like dementia villages and how we can support people in a different kind of environment to an institutional environment. Community services will be 7 days a week, and they will be 24/7, night sitting. We would call this a community independence service. For children, we want to connect care, and for this group particularly, GPs need to have direct access to our paediatricians in the hospital, and they need to be able to talk to them when they want to if they've got a sick child. So we would create those pathway links, and we're already starting to do that with our paediatricians. For our activity off the hospital, we are looking closely at that because we are confident if we can get the hospital working in the way a hospital should for specialist care, we can actually retain a lot of activity on the island rather than sending it off to the UK. We could do a lot more activity here, whether it's spinal activity, cancer services. There are many pathways that at the moment we send to the UK that we believe we could retain within Jersey. We just don't have the capacity to do it right now. This is just a quick example of our outpatient analysis. So we've talked to our teams, we've looked at the activity. For physiotherapy, our physiotherapists are saying 23,000 outpatient appointments happen in the hospital. Our physios are saying none of that needs to happen there. They could come here, they could go to people's homes, they could go to GP practices. We don't need to bring people into a hospital to see a physiotherapist. You need physios in the hospital to support people who are on the wards or in ITU or who need specialist inpatient physio, but you don't need to do it for a planned outpatient appointment. Community dentistry, 90% of the activity could happen outside the hospital. 23% from trauma orthopaedics, 7% ophthalmology, and it's important that you recognise though that regardless of that change in the way we deliver the service, the hospital will still provide all of the essential services that we enjoy today. It's incredibly important we retain that, and we are very lucky to have the services for our population. You wouldn't have that within a UK landscape. From an island perspective, we've got to retain that. So women, children, family care, fully functioning maternity unit, acute mental health services, an emergency department, theatres, critical care, medical specialties, wards, surgical wards, diagnostic services. But cancer, we think we could have a cancer centre here, and particularly a lot of our patients have to go to the mainland for radiotherapy, and we're confident we can start to provide that service on island. People with cancer don't want to have to travel, and their loved ones don't want to have to travel with them. We should really aspire to do better and provide that within Jersey. The new services will be a mental health place of safety, the urgent treatment centre. That will be connected to our, what we call our acute floor to manage our unwell patients. And as I said, radiotherapy and many other conditions that we could really start to repatriate here. I'm going to hand over to our chief nurse, Rose, and she's going to talk about how we can start to make the change in delivery.
Thank you. Good afternoon, everyone. I'm Rose. I've been a nurse for 31 years and I've been on this island for 14. And what I really want to stress before I start to talk about how we're going to deliver this model is that whilst you've heard a lot of information about the hospital and about the pressures within the hospital system at the moment, this care model is a whole system care model. So we've developed it across a whole system, and it will require the whole system to change in order to bring the care model to fruition, not just the general hospital. The other thing, just to make the point as well, is that this isn't a model that we would say we're going to do today's model today and the new model tomorrow. As I'm sure many of you have already worked out, there's a huge amount of work involved in making this model happen. So what today's about, and all our parish events is about, is having an opportunity as a team, clinical staff, representing the views of our other clinical colleagues to share our thinking with you around the model so that we can hear from you your thoughts around our proposals. So just in relation to moving on to our delivery model, so as Rob talked about our community provision at the moment. So we have fantastic nurses working out there in the community teams at the moment who are doing their very best in a system that doesn't provide care and choice 24/7 for people in their own homes. They're also doing that with a limited team around them. So they work very closely with their GPs, they work very closely with other professional colleagues, but we don't really have teams that are in place that can support you in your own home. So Rob gave the example when he said these teams can actually support people and keep you out of hospital. So this could be, you're not very well, your GP comes out to see you, or perhaps your district nurse, and they say, actually I'm going to bring in an extra team, I'm going to bring some more colleagues in to look after you. And they can operationalise a team called an intermediate care team that could have physios, occupational therapists, a social worker, a nurse, somebody who can do an odd job, so if you need a rail putting up in your home or whatever, so you can have a wraparound service that can help support you in your own home to recover from an acute period of illness. Absolutely, if you need to go into hospital, you would go into hospital. Your GP would make that call, or the team around you would say, actually, I think you probably need to go into hospital for this period of illness. Similarly, you could be in hospital, you could have had an operation, or you could have been in hospital because you've had pneumonia, or you've had an acute episode of illness. And again, you've got an option with that team that you can go home with a wraparound team to support you in your own home for a period, let's say, of about 6 weeks, where they give you some intensive support in your own surroundings and keep you at home. At the moment, our offer is very limited. And last night at one of the parish events, we had some of the nurses from the General Hospital sitting in the audience, and one of them voiced that how frustrated they feel for patients when their patient desperately wants to go home and there's a limited choice, and at the moment those people are going into residential beds to have their recovery because we don't have enough provision within community. So a big aspect of this is around moving resource that we currently have in the health and social care system in terms of people and in terms of money, and bolstering those services in the community significantly. So that's one of our key priorities. The second part is around how do we assure ourselves that when we move services out into the community, that they are safe, that you get a good quality of service, and that the practitioners looking after you are competent. And we'll do that through a different commissioning framework that actually drives through quality based on the outcomes of the care that's being provided to you. So whether that's moving services out, that you can have more services and more opportunities through your GP practice to different aspects of your care delivery, or whether that's in a community setting, such as your own home, we would have a commissioning framework that sits around that. One of the things I get asked every single day is around recruitment. And I have to say, the workforce is essential to this. We couldn't do what we do today without the brilliant workforce we have across the island, and we certainly couldn't do it tomorrow without them as well. I have to say, changing the model of care doesn't actually alter the challenges that we have with recruitment. But we work really hard, and we continue to work hard, to make it an attractive place for people to work by offering lots of opportunities. But I think conversely, changing the model, what we've heard from our clinical staff is that they feel that at the moment, the way that they are working means that they can't use their skills to their fullest potential, because they are in a frustrating position where they are caring for people that they feel should be better cared for in other settings. So our staff have said, if we change the model, this actually makes it much more attractive. And certainly in recent recruitment, I've made 2 appointments within my own team, and people are hearing a lot about what's happening in Jersey and are very excited about an opportunity to work at a different level across a multi-professional team. There's also more that we can do to grow our own resource within Jersey, and we already do a lot of this. We already train our own nurses, we train some of our GPs, which Adrian can talk about, and we've started a social work degree as well, but there's more that we can do. But the workforce strategy that needs to wrap around the care model needs to be an island-wide workforce strategy, not just a government one, but one that encompasses all those people who work in health and social care in Jersey. Rob's talked about a different review of our contractual frameworks around tertiary care. So this is, when we talk about tertiary care, this is care provided in another jurisdiction. And we do know from feedback that the pressure that this puts on families when their loved ones are off island having treatment in a hospital in the UK is significant. And we recognise that this gives us an opportunity to have a look at those services that we could bring back. We would always need to have some services provided off island. We've got to make sure that decisions that we're making are safe and clinically appropriate. So there will be services that will still exist and will still need services in the UK. But really looking at what we can do to lessen the emotional burden on families and bring people back to Jersey. One of the things that will make a big difference, and is a significant piece of work, and we talk about it as one of our main priorities, is around the digital support to making health and social care work much better. And we have got somebody who's heading up our digital work here today, so he'll be able to answer any of your questions on this. But just in relation to the digital technology that's available, this is about how we support workforce moving around the island to access records. So if I'm a nurse going into your home, I'd like to be able to see the records that your GP has. I'd like to be able to access information about your allergies to drugs. I'd like to be able to see what the care plan is around your recovery. So at the moment, our systems don't talk to each other. We're expecting staff to work across a community setting. We've absolutely got to be able to support them with the digital technology that is available, but also to support people in their own homes as well. So again, there's a lot of things that we can do in relation to managing people safely, supporting people safely, and giving you better access to information as and when you need it. But I'll leave the tricky questions to Stephen. Rob's talked about the mental health work stream, which was supported in the government plan and went through recently, so there is significant and much needed investment in our mental health services moving forward. But this, in relation to the care model, this is very much about early intervention, offering people opportunities to access support much sooner, making sure that mental and physical health are given equal priority and importance, So when we talk about these teams, making sure there is somebody with mental health experience on that multi-professional team as well. And we do know the connectivity between good mental health and physical health. The evidence is very strong. If you have good mental health, it does have a positive impact on your physical health as well. So again, right across the system, we've got to make sure that we have mental health and physical health at equal parity. Rob made reference to social care at the moment in relation to our domiciliary care market. So these are the people that often come from care agencies who go into people's homes at the moment and deliver hands-on care. And again, from the work we've been doing and from the conversations we've been having, we do know that this is a workforce sector that is under significant pressure at the moment. We're trying to do what we can to support that service at the moment, but we would need to deliver a different offering moving forward. And that includes making that an attractive career for people to go into, a career that leads to other opportunities, looking at terms and conditions. And we've heard, particularly through going to the parishes, some stories from people who work in these services about the difficulties they're having at the moment. So that's something that we've significantly got to address if we want to disrupt the current path that we're on at the moment, which is building more and more residential institutions. Partnership of purpose is something that we've talked about with our colleagues across the health and social care system over the course of the summer. And this is really in response to people saying to us, how do we fit into this? So this could be a charity, it could be an organisation that we currently commission, it could be one of the government-run organisations. But this is about people seeing how do they fit into the new Jersey care model. And a way that we can do that is through this partnership of purpose, which really sets out the key principles and the direction of travel, so every organisation can see the role that they have to play in that. Through those conversations, which have been really positive, that's given us an opportunity collectively to think about duplication that exists in the system. So just to give you a little number, there are 500 minibuses on the island at the moment that money has been raised for and all deliver a fantastic service. But those organisations are starting to talk to each other to say, what can we do to share our collective resource better and actually work together in a much more joined up way. So instead of everybody trying to deliver training, everybody having a minibus, everybody having back office functions, there's work already happening between these organisations that says, we'll do that if you do that, we'll do that if you do that. And again, it's just a better use of the resources that we've got. We can't do this on our own, as I said, and one of the key foundations of this model is around prevention. And it's never too late to change your habits, so I'll get that one in. But in relation to prevention, that isn't something that's just the role of health professionals. There is a whole responsibility from a society point of view. We'll deliver that through a new health and wellbeing framework that will really mobilise government to addressing and delivering on a number of key issues that affect people's health and wellbeing in Jersey. So we'll be delivering that through a framework. Vulnerable groups are absolutely key in terms of making sure that we safeguard the most vulnerable in our society. We need to make sure whatever changes we make to the way we deliver care in Jersey, that we're very mindful of those vulnerable groups and we ensure that there is ready access and no barriers in place for people accessing healthcare as and when they need it. And finally, just the last thing to say on this particular slide is about culture. And this is quite a cultural shift. It's a cultural shift for our staff, and we've had really good conversations with staff about how this would work differently. So again, I'll give you an example. We have a lot of nurse specialists within the island who are doing really brilliant work, but quite a lot of them work within the general hospital. Again, they would like the opportunity to work out as part of community teams to support people much earlier on, so that they're not just having to respond when you have an acute episode and find yourself in a general hospital. So from a workforce point of view, this is going to be quite a shift because we're asking people not to define what they do by the building that they work in, but to think about the whole system and working across the system. And again, we've got some good early examples of how we're making that happen now. And the other is around the cultural shift from ourselves as people who use those services, and we know that people hold the General Hospital in good esteem. You know, that's not surprising. Many of you have had your children there, it's there when you need it, and sadly some people have said goodbye to their loved ones there. And as Rob said, this is not about not having a general hospital. It will still be there when you need it. This is about giving people more choice in relation to care and actually enabling the hospital to focus on the acute services it needs to provide. So just to reiterate our commissioning intentions, money will follow activity. So whether that's around moving some of our chronic disease management into the hands of our GPs, supported by other professional colleagues, if you don't pay for that service now, under this new framework you will pay for it then. So if you've got a respiratory problem that you currently go to the General Hospital for, to see a specialist, those services, when they move out, the GP will have access to those specialists as well, so it's not about saying everything goes out to the GP and there's never a specialist involved again. It's about the money following the activity. And if that's in community care as well, the money will follow the activity in terms of the services that we're developing. And then finally, I have mentioned it whilst I've been talking, but we genuinely haven't developed this in a dark room at the General Hospital. We're representing a lot of voices here today, and over the course of probably the last 4 months we've been very busy listening to people, talking to people, having discussions and conversations about the new care model. That includes with 3,000 staff that we have in health and community services. Rob's already said he's met with all the GPs, that was his August job, and had conversations with them about the model and how things are working at the moment and how we can change things in the future. Myself and Paul on the front row have been busy with our external partners. There's about 450 plus that work in Jersey, which is a fantastic number. I must confess we haven't got round them all, but we've spoken to a huge amount of people over the course of summer who are really up for being engaged in something different in the future. And finally, as I said, we can't do this on our own, so this would require government to work with us right across the whole of government. So again, we've shared this presentation with people, we've had conversations and we've listened to their feedback. And we have presented it to our political leaders as well, so we've presented it at a political oversight group for the new hospital and also to the Council of Ministers. So I'm just going to pass back to Caroline, who's just going to wrap up.
So this model has not involved any external consultants, any of the big 4 firms. This has been done by clinicians within Jersey. And there are 3 key messages that we'd really like you to hear. There will still be a general hospital with all of the facilities and services that you currently enjoy. This model will not pass cost on to patients. Care that you currently receive within the hospital that is free at the point of access will still be free at the point of access, but would be delivered within a different setting. And finally, if this model is supported by islanders, this model will absolutely allow us to do procedures on island that we currently have to send islanders away for. We will be able to do them here. So it's over to you for questions, comments, observations. We've got a mic at the back.
No? You've got 9.
Right, I'll have to go.
We've only got 1.